must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show.
Hi everyone, I'm Stephanie Wyrock, and welcome to another episode of the Healthcare Education Transformation Podcast. Today I'm joined by one of my friends and a special guest, Jessica Schwartz, who is a doctor of physical therapy and an orthopedic residency-trained physical therapist, a national spokeswoman for the American Physical Therapy Association, host of the Concussion Corner podcast, former program director and founder of the Evidence in Motion Concussion Certification, a post-concussion syndrome survivor, advocate, and concussion educator, and also one of my personal friends and mentors. So welcome, Jessica, to our podcast. I know that, I covered a lot about kind of your credentials and how you've come to this specialty of concussion care. Tell us a little bit more about yourself and kind of how you got to where you are today.
Hi, Stephanie. Sure. Thank you guys for having me on. It's an honor and a pleasure. You guys have been rocking it with this podcast, so congratulations.
Thank you. We love that people are listening, and we're so happy that you listen to our podcast too.
Yes, yeah, I've been a fan since day one. So you guys have been rocking. It's hard as you become a producer of podcasts to actually listen to. So you guys are one of my top 5 that I listen to.
That's great. We love the Concussion Corner podcast. It's one of my favorites as well. I know as a newer clinician, kind of getting into this concussion realm, it's something that I have dealt with a lot of as a generalist. And so, your podcast has really given me some great ideas in treating patients, making sure I'm not missing diagnoses. And, kind of along those lines, how did you get into specializing in concussions, and kind of what's your personal experience with that?
Yeah, so thanks for asking. So essentially what happened was I was hit by a car. I was hit by a car in 2013, October 3rd, 2013, right here in New York City. I worked at a wonderful clinic where I did my residency through and then became a junior partner, ironically, the week that I was hit at the company. And what I thought was just going to be, 7 to 10 days, like all the literature said, recovery turned out to be 14 months of hell. I was supported by a lovely team at NYU Concussion Clinic, but I was in 10 to 14 hours of rehab a week for 14 months. So as I was going through that process, I said, okay, we've got to make this better. I ended up getting into a social media support group through Facebook for concussion and post-concussive syndrome. And what I did, because I was a healthcare provider, right? I didn't really want to get too involved because I didn't want to put too much of my business out there because it is the social media at the end of the day, even though it was a closed group. But I was like a voyeur, and I watched for the first 3 to 4 months. I just watched the same story being told internationally. It was the same story. It didn't matter if there was a third-party payer country like the US is. It didn't matter if it was international between Canada and Australia. It was all the same story of people essentially being mismanaged, more prevalent than they were being well cared for by the healthcare community. So what I realized was that there were so many inconsistencies, more inconsistencies than kind of well thought out treatment plans and people even being aware that this was a rehabilitative injury. So I said, I'm going to change this. And I said that in the middle of my treatment. I think I told my occupational therapist, Meg Waskowitz over at NYU. And I said, I've got to change this. This has got to change. And I thought I was going to be like a door-to-door salesman, but it turned out I had lovely opportunities from the physical therapy and medical community to kind of share my story, tell my story, and then create some educational opportunities internationally. So it's been a neat ride.
Yeah, I know that you're an official spokesperson for the American Physical Therapy Association. As an official spokesperson, how have you kind of gotten the message out there about how physical therapists can treat people who have gotten a concussion?
Yeah, so it's been a pretty neat opportunity. I have to be honest, I told Erin Wendell when she reached out to me. She's one of the heads of public relations over at APTA, and she reached out to me in 2015. And she said, we would love to have you be one of our spokeswomen. I had a couple articles go viral with a blog. And I said, oh my gosh, I didn't know this was a thing. And of course, I've been wanting to be a physical therapist since I was 15. And I said to her, I was like, with all due respect, I talk to everybody else but PTs. PTs kind of tend to do this. And no matter what business you're in, if you're in the restaurant business or if you're a physician or an athletic trainer or neuropsychologist, whatever your position is in life, you tend to corral with the people that know you best and kind of talk about the problems and how good you are. But I said, you know what? I just want to talk to folks that aren't PTs about how great PT is. And that's kind of what I've done consistently through my career, publicly through social media and speaking at conferences, and everything else just kind of falls in line. But for physical therapists, I really believe that physical therapists should be one of the top two disciplines alongside the physician to evaluate, assess, and treat concussion. And I mean that with an asterisk, with training. All of this requires training. But we can get into it a little bit later, but 5 of those 7 trajectories are really in our wheelhouse of concussion. And we really have to start taking ownership of this and to have to start getting post-professionally trained and how to treat this comprehensively from a 30,000-foot view and then right in there from tunnel vision.
The definition of concussion has kind of evolved over the years. How would you define the current best scientific and universally accepted definition of concussion in today's standard, and how has it evolved over the past, say, 10 years?
Yeah, well, evolution in the past 5, 10, and 30 and 100 years, we've really, been calling this injury of a concussion. In the past, we've been calling it like I got my bell rung, or that kid got their bell rung. And, concussion is synonymous with mild traumatic brain injury. They are the same thing in 2019. The issue that we have is we actually can't agree on a working definition of concussion. So there are actually over 43 working definitions of concussion, and only one of them is evidence-based, and that's still today in 2019. So that was the same, 3 and 4 years ago, and still the same today. So how I define it is really simply, I want to make sure that because the brain is gray and white, but literally gray, no pun intended, there's a lot of gray zones. So I'd like to make it really simple. It's any blow, bolt, or jolt to the head or body that causes neurological symptom. So concussion is a change in brain function, following a force to the head, but most people also don't associate it with a force to the body as well. So I always say, think back to your college days, and if you ever fell off a bar stool and landed on your butt, and that reverberation went all the way up through coccyx, through spinal cord, all the way up to the head and neck. If you got a headache, that technically is defined as a concussion, or a little confused or lost your balance, that's defined as a concussion. So most people don't even realize that they have been concussed in their lives, and they don't associate it with that. So we don't have to have a temporary loss of consciousness. Less than 10% of people do. Most people are awake individuals, and we really are looking for changes in both neurologic and cognitive dysfunction. So, for example, if that kid on the sideline gets concussed, God forbid, they start running the opposite direction than their team. That's a shift in cognitive function where most people will laugh. That actually is considered a brain injury. And as healthcare professionals, ATPT and physician and beyond, we all need to make sure that we're taking these injuries seriously and then assessing the patient with a comprehensive targeted physical examination.
I think you make a really good point that a lot of times people don't even realize that they've had a concussion. I know that as a clinician who sees people in my clinic who have concussions, this is very common. A lot of times I'll see patients after they have their 2nd or 3rd concussion, and they always say to me, I don't know why I never came to see a physical therapist before. I feel like my recovery was a lot faster now than it was just trying to sit and rest. So with that in mind, if someone is presenting to the clinic without a diagnosis of a concussion, let's say they have neck pain or whiplash associative disorder, what are some of the key subjective and objective examination signs that can maybe lead us as clinicians to an increased suspicion of concussion as being a part of the symptoms that maybe we need to treat or inform a physician about?
Well, that's a great question. And the issue with concussion is that it's a non-specific injury, right? So it's a specific and non-specific injury. And we can have both a central injury and a peripheral injury. So for example, the neck, right? The cervical spine. And I don't know if have you ever seen the like CDC infographic stuff about like, is it the cold or is it a flu? Have you seen that where there's like a checkbox?
Yes.
Yeah, so that's what we have difficulty. Sometimes it's a diagnosis of inclusion exclusion. So for example, just to give you an example with like the cervical spine and concussion, if they're both injuries, right? We can get headache, dizziness, sleep disturbance, blurred vision because of that CO to C3, afferents with the cervical spine, blurred vision, neck stiffness, balance disturbance, depression, cognitive deficits, decreased cervical range of motion, and decreased isometric neck strength. We can see that all of those symptoms with both a cervical injury and a concussive injury. So there's a lot of overlap. So that's why we don't ask patients how they're feeling. That's why we have to do these comprehensive and targeted physical examinations. And I'll give you the link to that for your audience by Matuzak, Letty, and all. There's a 45-minute sample, and then there's actually now a new 4-minute example for the sideline, because that's often as much time as we can get if we're in an athletic endeavor. But if you're in the clinic, you should be really doing the longer, more comprehensive exam to tease out other symptoms and systems, I should say.
Yeah, I think really making sure that we're examining the cervical spine as a source of symptoms as well as how it relates to their symptoms is something that we need to be mindful of as clinicians. I would say that probably 80% of the time when I see people with concussions, there's some type of cervical spine involvement. So I think you make a really great point, Jess, that we need to make sure that we're kind of including all of these parameters and really thinking about the whole person when they're coming into our clinic. What about the vestibular ocular motor screen? Tell us a little bit about what this is and how this can be effective in helping diagnose concussion as well as treat concussion.
Right. So we have the VOMS is what it's called, and it's supposed to kind of sound like vomit, to be honest, because it can induce some significant discomfort in your patients. And I have to say, when the number one thing I hear as a physio internationally in these support groups and in patients that reach out to me after being seen by multiple providers is actually that their quote unquote vestibular therapist made them worse. And that's why I say, not only as a spokeswoman, but as a physical therapist and just as a human in general, is that we really need to meet the expectations of our patients, especially if you are in the vestibular realm. And the reason why, even if you're a generalist like yourself, Steph, that if you're going to do a vestibular ocular motor exam, which was an exam that was developed out of UPMC by primarily physical therapists and a team of other interdisciplinary rehabilitative colleagues. But it's basically an exam that you can essentially do in about 5 minutes, maybe a little longer if you're not as skilled or if your patient is very symptomatic. And basically it's looking at baseline symptoms and looking at the vestibular ocular system. So for example, we'll be looking at smooth pursuits. We'll be looking at saccades, horizontal and vertical. We'll be looking at near point convergence. And then we'll be looking at the VOR in horizontal and vertical, and we'll assess for visual motion sensitivity. And essentially we're looking to see if there's a 2 to 3 point change in the patient's headache, dizziness, nausea, and fogginess. And then we assess from there and then score it 0 out of 10. So essentially you want to make, and the reason that the VOMS was created, to be quite frank, is not just for a physical therapist to do it. Physical therapists have much more in-depth training in the vestibular system than the VOMS. The VOMS is something that was meant to be done by other practitioners that are not skilled in the vestibular assessment and screening. And as a generalist, you should be able to screen quite comprehensively, Steph. Straight out of school, straight out of DPT school in 2019. That should be something that our graduates are comfortable with here in America. But the vestibular ocular motor screen was made for not just physios. So it really needs to say, hey, Are we assessing the vestibular ocular motor, systems? And are we able to provoke symptoms? Is this provocative for the patient? If it is, then I better be darn sure I'm referring to a vestibular physio or OT and that specializes in concussion and brain injury.
I know that it kind of varies on patient to patient, but for those people who maybe don't see a lot of concussion, what is generally expected for recovery when somebody comes in for concussion? And what's the difference between a slow responder to physical therapy and quick responders to physical therapy?
Great question. So we really don't have a time frame and a little bit of history behind this. There was incorrect information put out in 2001 by some very wonderful researchers, and it wasn't any fault of their own. But again, we don't really have a working definition of concussion in 2019, let alone 2001. We know it takes about 8 to 10 years for research to get published and to take place. And then it takes about 14 to 18 years for research white paper publications to actually get translated into clinic. So we're kind of at that time. It's 2019. This was published in 2001. Most people think it takes 7 to 10 days for people to recover from concussion. Well, why is that? The historical component for that is actually because of this NCAA, National Collegiate Association, Athletic Association research article by Brolio and McRae, who are wonderful clinicians, who published this article that it says it takes 7 to 10 days to recover from concussion in high school football. Now that was taken and translated everywhere in the press and in other articles and things like that. Well, if you fast forward to today, and we have the world's first prospective study on brain injury and concussion in both the Department of Defense and NCAA. It's called the Grand Alliance CARE Consortium. So this is the CARE part of the Grand Alliance. Millions and millions of dollars have been put forth from our government in the US to look at, blood work and MRIs and imaging, which is still even ahead of where we are with this injury. Concussion is a clinical diagnosis only. But going back to recovery, we're seeing that we return players back to play in 6.65 days in 2001, between 99 and 2001. It took duration of symptoms that they found in 2001 were 3.4 days, and then they actually got them back to play in 3.25 days. Well, today they're actually average return to play in this 35,000 plus student with control, mind you, it's very important here, with control, 35,000 plus students and cadets. They're actually finding that on average, it's 14.3 days after suffering a concussion, student athletes are returning to play on average. Now, what does that mean, Steph? That means that high level, trained, cardiovascularly trained and strong athletes are going back to play in 14.3 days with skilled supervision and trained to get back there. Now, if we rewind back and think about the general population, we have 100,000 NCAA athletes, okay? It's either 100,000 NCAA athletes for football or all athletes are 100,000. But either way, we're gonna stick with that 100,000 right now. We have to remember that most TBIs, traumatic brain injuries, and concussions actually happen because of falls, car crashes, and things like that. So literally getting hit in the head by a shelf or a garage door. Most concussions don't happen to elite athletes. So there's an article by Henry et al. In 2015, and that article talked about average return to life and activities were really 28 to 30 days by this Henry et al. Article. So I really think you're looking at expected recoveries between 2 and 4 weeks. I push the echelon because I really push my patients and challenge them functionally in all their environments, whether it be familial, they have to multitask with kids, cognitively in a kitchen, do other tasks vestibularly, and turn and shift their heads and bend over, and also do things functionally like large squats and push-ups. Can they change positions and roll without any sign and symptom, and so on and so forth. So I'm really seeing on average the quote unquote acute recovery being between 3 and 4 weeks when they're usually in my hands, and then I see folks usually a year out. Well, when they come to me, they usually call because they've had some kind of protracted recovery. And that does happen too. Anything beyond 3 months, we call a protracted recovery.
So what would be the difference then in treating somebody who maybe is more acute versus maybe somebody who comes to outpatient after being maybe doing their resting for about a week after they have a concussion? What's kind of the difference that one would see if they're in those different settings?
Well, if you're seeing someone anything, more chronic, right, you really have to address the fear avoidance component of their day-to-day lives. They don't know why they're feeling ill by basically turning their head to the left or rolling over in bed too quickly, or going into the grocery store because the lights and the colors are too, they have space and motion discomfort. When we don't know what to do with somebody in medicine, we tend to go down two trajectories as clinicians since the beginning of time. We either elude that they're malingering or we refer them to psych. So they must be faking it if Dr. Schwartz, cannot figure out what their diagnosis is and why they're not feeling well. And that is with full sarcasm there. So we have to make sure that we're teasing out the systems that are provoking symptom, and we have to make sure that we, very Dunning-Kruger-esque, we know what we're looking for. Because if you don't know what you're looking at, you can't know what you're looking for. And most patients in this protracted recovery and even early on were actually presenting with physical somatic symptoms: dizziness, space and motion discomfort, getting agitated due to neurofatigue and cognitive fatigue. Very different than physical fatigue. Neurofatigue, cognitive fatigue, you cannot think anymore. And then the patient may become agitated and show more behavioral symptoms. But we have to remember that 5 of 7 of those trajectories, which we can talk about later, vestibular and things like that, have an anxiety overlay. So you have to make sure that you're looking for somatic things as well as the cognitive, sleep, and mood disorders that often are associated with concussion. But you have to make sure you're understanding where they're deriving from.
Yeah, I think that you make a really important point there, Jess, that we need to really make sure that we're understanding the patient in front of us. So, when working on exercises aimed at addressing some of these issues that we're finding, especially during our VOMS exam, what would be the appropriate response to exercise? What are some signs that we can look for as physios that an exercise is too easy, it's about right, it's too hard? How would you recommend those?
So there's a few things here. We're not just exercising to exercise. We want to be really specific with our exercise prescription. So we're going to be exercising a few things if we're teasing these things out. We may have some cervical spine dysfunction and some whiplash associated disorder. So we're going to be wanting to go with those protocols that are, best known by, Tim Noteboom or Jim Elliott, Tim Flynn, and those guys on our cervical spine, clinical prediction guidelines. We're going to be wanting to pay attention to those guidelines for whiplash. We also want to pay attention to the cardiovascular system and autonomic responses. We often have deficits in the autonomic responses to exercise with concussion and brain injury, and we're finding it more and more. Not only is it prognostic, it's also diagnostic. So we want to make sure that we're putting our patients through the Buffalo Concussion Treadmill Protocol, or out of University of Buffalo by John Leddy, or he's actually developing a bike test for those that are too vestibularly sensitive to be on a treadmill, or are just unsafe cognitively or age-wise to be on the treadmill. He's working on a bike protocol as well. So we want to make sure that we're addressing the autonomic responses, not only cardiovascularly, but also if there's a change positionally. So we want to be able to challenge our patients positionally, whether that be supine side lying, sitting to standing to prone, and then large muscle groups, kind of like a burpee, of making sure that they can change positions without symptom. That's a big safety issue, especially. I also want to be looking at their dual tasking. I am challenging them not only physically, but cognitively. I have to make sure that they can think and move at the same time. And we know from our Alzheimer's research and dementia research that thinking and moving are totally 100% correlated and related. So I want to make sure that I'm also challenging my patients dual tasking, whether they be geriatric, pediatric, or everything in between. So I want to make sure that they can be able to dual task and think and move at the same time, and sequence and plan. This has also become the safety issue. I also do it cognitively. If I have like a chef, I want to make sure my chef is not going to grab a hot pan in the kitchen, if they're a sous chef or an executive chef, because they're unable to sequence and they're getting overload with their processing. So that's something that we want to just be mindful of, when we're working, because physical therapists are really experts in function, and we have to assess our patients' functional abilities in all realms of their life, family life, professional, social, you name it.
Well, and I know that in, a lot of the neurological research that's been going on, one of the most important aspects of making sure that people are making good gains in therapy is the dosing aspect. A lot of times exercise is underdosed in people that have neurological conditions. So what is your recommendation, or what does the research tell us about dosing for a home exercise program or for therapy in these patients that have had a concussion?
Well, just to for all patients, and then bring me back to the question again, Steph, 'cause I'm sure I'm going to forget it. But with all patients with concussion and brain injury and any other neurological disorders, or even just aging, okay, processing capacity of the conscious mind is about 120 bits per second. So think about like a really old computer, like in the 80s and 90s. Okay, we have these like supercomputer, iPhone, Android phones in our pockets these days. Well, as people, as one person, neurologically intact, we have about the ability to process 60 bits of information per second. So if we can process 120 total, if we're having a conversation between you and I, that's about 60 bits of information per second that's being processed in my mind and your mind. Which that means is that if there's somebody kind of talking in the background, if there's like a dog barking or some ambient noise, that means I can usually, as a neurologically intact person, filter that out. Well, what are most clinics like? Most clinics are not closed one-on-one rooms. Most clinics are open either in a hospital setting, a private practice setting, in a gym setting, whatever the setting may be. It's usually not one-on-one. There's usually something else going on. Even if it is one-on-one, there's usually a little music in the background. Well, number one, before you're prescribing anything, you want to make darn sure that your patient is processing the information that you are trying to give to them. So we have to make sure that, for example, front desks may need to call and remind the patients because they may forget. These patients are brain injured. They have neurological injuries on top of everything else that might be going on. And other anxieties, losing family, losing children, losing jobs, losing health benefits, so on and so forth. So usually physical therapy is not number one on their list, okay? Number two, you wanna make sure that you're also using your teaching and learning skills from that entry-level, education in physio, whether that be international or domestic here in the US, that you're making sure that you're writing things down or giving the patient information that they can process and complete. The completion, you want to make sure we're setting your patient up for success. Concussion is an injury of loss. So we want to make sure that we're not overloading the patient with things they can't achieve, because that just then the rehab process becomes another area of loss in their life. So you want to make sure that you're sensitive to that. So when you are prescribing, you want to make sure you're either writing things down, keeping a journal for them, just in their, like a concussion journal. I actually will literally buy and give planners out to my patients that are really concussed, because it'll set them up for success at the end of the day. I'll put their doctor's appointments in there. I'll also put their home exercise program in there. And every day we will write something in it so they have something tangible to go back to. It sets me up for success as the clinician because they can do the thing at home, they won't forget, and it sets the patient at ease, which will ease some of their anxiety, which will allow them to do and free up some cognitive space to do the actual activity that I'm prescribing.
That's a great idea. I've never thought about handing out like a planner, but it makes total sense. So my husband is a pathologist, and he recently did a talk on CTE and kind of the pathological findings that a pathologist will find in the brain following somebody who dies from CTE. And I'm wondering if you could maybe comment on chronic concussions and some of the popular culture that has surrounded concussion in sports, and kind of how that has changed how we see and treat concussion in society today. Okay.
Well, one thing I say, with all due respect to people who are living with diabetes, is I say that CTE should be diabetes should be much more scary than CTE. I have people coming up to me, whether I'm at the Super Bowl and hosting that event out there, thanks to the Brain Treatment Foundation and all those lovely ladies, over at that nonprofit, or traversing the halls over there. Where was I? In Minnesota at the Mall of America. I had at least 30 very large men and their wives and families come up to me and says, Jess, I know your story. I have CTE. I have CTE. Whoa, we've got to back this up. So we have to make sure that we know that living patients, we cannot diagnose chronic traumatic encephalopathy in the living today in 2019. We just can't do it. There are some preliminary tests out there that are eluding that, but we have to also make sure we know what we're looking for. We do not have a common definition of TBI, traumatic brain injury. We do not have a working definition besides there are 43 working definitions internationally of concussion. So we want to make sure we know what we're looking at so we can define it is very important. The other thing is, living a life of a sedentary lifestyle and actually not moving is actually much more dangerous than actually moving on a soccer field or a football field and things like that. Now, the big caveat here, because I don't want to receive any angry emails or death threats on social media, is that we have to make sure that we are listening to the people who are doing the research and the experts here. Now, what does that mean? We've actually made rule changes in the NFL, which then trickled down. We have 1,000 men that play in the NFL, okay? We actually know that there are more high school girl concussions in soccer than boys football concussions in high school, both high school comparisons. So we want to make sure that we are trickling down from, the pros down to the youth leagues where there are millions of youth athletes versus 1,000 or 100,000 NCAA athletes. And then we also want to make sure that we're safely moving our kids. So we're not moving our kids into multiple sports per season. We want to make sure we have periodization and rest. Some basic certified strength and conditioning specialists, advice. We have to make sure that the weekend warrior is not playing 4 sports on Saturday and Sunday and then, playing 5 days a week or not resting and things like that. So we want to make sure that there's a fine line, and that requires guidance and listening to U.S. soccer, listening to U.S. football, listening to the rugby associations. If you're knocked out in boxing, you have to actually take a mandatory rest of 90 days, no sparring, no contact. So you want to make sure that you're listening to your governing body, because we're actually seeing that about 24% of people are listening to the guidelines for both soccer and football with regards to contact in practice and heading. So we just want to make sure that we're following the guidelines that we are putting out at, quite frankly, record pace the last 5 years that most people are A, unaware of, or 2, are just not abiding by. So you want to make sure that you're surrounded by a good medical team and or a good coaching staff or league. And if you're listening to this and you're a physical therapist or a healthcare provider and you live in a town and you didn't know about any of these things, bring it to your town's youth sport league, the rec center. Make sure people are aware of what the new rules are for concussion, because there are new rules in 50 states. They all vary to a degree, but they're pretty much similar throughout.
I think you really make a good point on making sure that we understand the rules and that we're helping our communities abide by these rules and protect some of the youth athletes or even sedentary individuals that end up having a concussion. And I know that over the years, these changes have obviously come about relatively, I think, slowly. But can you comment a little bit about how the treatment of concussion has changed over the last few years? Kind of looking back even to like the 70s and 80s, where if you got knocked out, you just went back in, and it was kind of seen as a sign of pride that you didn't comment or didn't complain about the injury, to now kind of taking that mandatory time off of the sport to try to recover.
Yeah, there was a CMU fires a gymnastic coach for urging an athletes to lie about concussion. And this is a collegiate level coach that was asking his female gymnasts to lie about their concussions so that they wouldn't miss practice or this national championship situation. At the end of the day, we want to make sure that we're educating our athletes that, you have one brain, and it is not a sign of weakness to, identify or potentially call out your athlete on the field. Like, hey, you know what? Jimmy's running in the opposite direction, or Jimmy doesn't seem so right. We want to make sure with any sign of confusion or, literally being dazed, confused, off balance, just feeling off, or just, Jimmy really well. You practice with Jimmy 5 days a week. You've known Jimmy for 16 years. Something's off with Jimmy. You got to let somebody know that Jimmy's not right, because Jimmy may not have the ability. We don't have the subjective language to express the what and how we feel with concussion and brain injury. So there might be actually somebody else that pulls you out of the game, whether that be a line, if you're working in a factory, a truck driver that might be at a truck stop that just got in an accident, or someone on the soccer field. In terms, going back to your question about rehabilitation, in the early 1990s, we were literally putting players back into the game same day, same practice. Okay, Jimmy got concussed. Jimmy, can you do the alphabet? Great. Jimmy, you're back in the game. If you're a good enough player, Jimmy was back in on the line. Today in 2019, we call concussion a rehabilitative injury. Concussions are rehabilitative. We need to tattoo this somewhere, put it in the sky, get it on billboards. Most people don't know this, including folks in the rehabilitative community. I don't say that in jest. I say that's very. We internationally, and the international consensus statement, it's been coming out since 2004, every 4 years, like the Olympics or the World Cup. Last one came out in 2017 from 2016. It was published in 2017. Free open access on BJSM. Everyone should have that in their clinic. We called that in 2012 when it was published in 2013. The neck, the cervical spine was just incorporated into that definition of the injury. So we just started including the cervical spine, that whole stick that, transfers afferent and efferent information from the body to the head, which is nuts. Which we've all known this, whether you're in the chiropractic or the physio world. We've all known that the cervical spine is very important. And I have to give a shout out to our neurooptometry friends. Our neurooptometrists know, and our migraine headache fellowship docs and physicians, they know that upper cervical spine is so important for vision and migraine and headache and autonomic dysfunction. And oftentimes, with that whiplash-like movement, whether it be in a car or head to neck on a field or a floor, that's so often involved and it's so overlooked. And then 2017 was the first year that we internationally called this a rehabilitative injury, which is crazy because as physical therapists, we were literally rehabilitation aides. And World War I is how we started as a profession here in the United States. And the big thing there is, well, what were we treating? We were like souped up athletic trainers on the sideline treating brain injury in the trenches. Like literally, people's craniums were blown to bits. And we were treating these men in World War I, traumatic brain injury. What did we do when we were neurologic, DPT students or PT students in the neuro ICU? We were getting patients moving. We've got the Foley bag attached to the scrubs. We're dragging the oxygen tank. We've got the pole, dragging the pole down that, and we've got the patient. You've got to have all these things. But we've been moving moderate and severe TBI patients since day one. Why are we telling mild traumatic brain injury and concussed patients to rest for months and years at a time? It actually goes against our oath of doing no harm. It's actually doing harm to patients. So we want to make sure that we're looking at the patient as a whole, the vestibular ocular motor system, sleep, cognition, cervical spine, headache and migraine, and I think, and the autonomic system and their ability to exercise. We have to be looking at them from all realms of their being, of their person, of their I am.
So what would you I know you have mentioned a couple articles that people can look up and a couple resources that we can go to kind of help us with managing people with concussion. But, besides the ones that you've named, are there any other resources that you would recommend to the newer physical therapist, clinician for concussion management?
Yeah, it's not just the newer clinician, to be clear here, it's really for everybody. 2015 was that first formal didactic year that neurology physicians were trained in concussion. The brain doctors, brain physicians were trained formally, didactically on concussion. So this is all physical therapists, this is all clinicians. There's a wonderful article by Matuzak et al. called a practical concussion physical examination toolbox, evidence-based physical examination for concussion. And it goes through the differential diagnosis, the physical exam domains and elements, mental status exam, neurological exam elements, cranial nerve assessment, manual muscle testing, which isn't so important for this group, but still important to know how to do, musculoskeletal exam, balance coordination exam, vestibular ocular exam, and the ocular ophthalmologic exam. They then dwindled that down to a newer article that was published in 2016. The newer article was published in 2018 in the fourth quarter that dwindles that down to a 4-minute exam. I really do believe that you should intimately know that 45-minute exam, and then as you become more experienced, then tease it out to 4 minutes. So that's one important one. Everyone should have the BJSM 2016 published in 2017 International Consensus Statement. You must have that. And there's some wonderful resources over at brainsteps.net. And they have free open access return to learn concussion series by some wonderful physicians, clinicians, and PTs. A shout out to Lenore Herget over at MGH. She's one of my favorite physical therapists that's doing this work in concussion patients out of Boston. And Get Schooled Concussions are actually the same people, but Get Schooled on Concussions is great as well. Also free open access. If you're an APTA member, ptnow.org is a wonderful resource. The orthopedic section will be publishing a clinical prediction guideline in 2019, I believe the third or fourth quarter. And then two more really helpful websites for your listeners are onf.org. ONF is the Ontario Neurotrauma Foundation, and they have about a 230-page free open access document that's in its second or third publication that is phenomenal. It touches on everything. So I really recommend that. Go to Staples or your local print shop, get it bound, get it printed. Even if it's $100, it's literally a free 200+ page document for clinicians and patients. So there's 2 different documents, and there's also a pediatric one as well. So that's onf.org, Ontario Neurotrauma Foundation. And then the last one is wonderful, especially with spring sports coming up in summer, is the Virginia Tech Helmet Rating System. So you want to go to beam.vt.edu, and there's a helmet section, and it has listed literally everything from football, hockey, bicycle. Youth football's new, bicycle's new. They've got sensors and soccer sensors now. And they rate them just literally like we rate cars. They're using some crazy biomechanical, physics, system, and testing these things, and it's all done independently. So I would be lying if I didn't say that I literally just bought a new bicycle helmet based off of this information, actually.
Those are great resources, Jess. And to our listeners, we will definitely have those in the show notes. So check out the show notes so that you can download those resources and utilize them in your practice. You had mentioned that now physicians, especially people who specialize in the brain and in these types of injuries, are now getting didactic work in their residencies, fellowships, in their training, so that they're better trained to treat people with concussions. Do you think that there should be more concussion or sports rehab emphasis in the DPT curriculum and on the NPTE?
Yes, it doesn't necessarily need to be on the NPTE. It needs to be across all specialties, specifically, it's all specialties at the end of the day, because we have more geriatric people in a couple years in this country than pediatric people, 17 and under. We're going to have more 65 and overs than 17 under. Needs to touch geriatrics. People who are 65 and older that are working still because of whatever reasons, they're still active, they're still cognitively fit, they need to pay their mortgage or their student loan still. I'll probably be in that situation. They're still working. Just because they have a concussion does not mean they have dementia. And so much of this population gets misdiagnosed. We don't challenge them enough as physical therapists. That needs to change. And I think that is changing with some good work that's being published out there and spoken about. We need this for the pediatric population, 101. We need this for sport. We need this for neuro for obvious reasons. We also need this for orthopedics. The orthopedics, we need to know how to look at the neuro signs and symptoms. The neuro people need to look at the peripheral signs and symptoms. We need to be able to combine them. We need to do this from a sport aspect as well, not only from an emergency medical responder, sport physical therapist, but we also need to be able to do this for return to function abilities. And even I would even challenge the cardiacs, the cardiovascular section, the cardiopulm people, because we need to be able to have this intellectual conversation about autonomic dysfunction and what that is, and that these people are not having heart attacks, but they're doing very low load activity and they're having this mismatch in symptoms. So doing a 3.0 mile per hour walking activity on a 3.0 incline in a controlled environment that's not 150 degrees outside, like in Doha, where our world president is located right now, they should not be at 165 beats per minute if they're an athlete with no other cardiovascular issues. So we need to be able to look at that from all aspects. So I say this if you're a new grad, and I really say this if you are a more seasoned clinician out there that's kind of maybe a little bit on the burnout front, and you can't look at one more ACL or high ankle sprain in your career. I really challenge you to get into concussion, because you have to be sharp on all aspects of the body, of the mind, sleep, cognition, you name it. You've got to be sharp in all aspects.
I love how you relate this to not only every system of the body, but also through the lifespan. As physical therapists, we are lifespan practitioners. And so making sure that we can help people no matter what stage of their life that they're in, if they have a mild traumatic brain injury or a concussion, I think is really important. And physical therapy programs now, it seems like there's always something that they should be integrating more into their curriculum. So what advice can you give to physical therapy programs to help them integrate something like a niche topic of concussion to help benefit their students? What are some strategies that you've recommended that physical therapy programs implement, or what have you seen work in programs that you've maybe collaborated with?
Yeah, I'll be honest with you. I haven't seen a whole ton work. And I mean that with all due respect to our practitioners, unless folks are really at an advanced, in-house place that has really advanced concussion clinicians that are a part of the faculty. There's a lot of mismatching information out there that's either old or incorrect, because there is a fire hose of information that flies out there. So folks that are like in the Boston region with like Lenore Herget and that crew out there tend to have very advanced new information. Folks at Duke DPT with Dr. Karina Martinez, both a PT, ATC, one of the best in the biz, for concussion. They've got her new data information. So again, if folks aren't really up to date, and this really is a full-time job to keep up to date, I'll be very honest. You've got to bring in folks that are up to date, on this information, whether it be myself or, a slew of other people out there. You want to make sure that very Dunning-Kruger-esque that we're giving our young physios to be out there the best information that we can. And sometimes it's literally just planting seeds of information and giving them the tools and places of where to look so that they can build it out. Because quite frankly, at the end of the day, we need to make sure that we're supporting our physical therapists, our future doctors of physical therapy with entry-level testing information so they can pass their, NPTE exam. But at the end of the day, this is much more, and as a responsibility as a doctor of anything, clinically especially, we want to make sure that we're providing our students with information that they can go translate out there after graduation, because quite frankly, it's not about if, it's going to be when they're seeing a concussion patient. 1 in 4 adults either know someone who's had a concussion or has had one themselves. So we want to make sure that if they do have any protracted recoveries or just need some guidance out there so they don't harm themselves, for example, working out too hard early on after a brain injury, falling again, having an episode of like a POTS, postural orthostatic hypotension, or anything else that can go on, You want to make sure that people have skilled guidance out there, and who better to access this than by a physical therapist with direct access in all 50 states.
Okay, so Jess, you have met many other people involved with concussion management. What are some of the most innovative and effective strategies that you found when it comes to fostering interdisciplinary education with this specific condition?
I think that touches on a couple of things. I think at the end of the day, for the patient, a skilled practitioner in the concussive realm really knows how to listen to the patient and validate their symptom profile. The number one thing a physical therapist or any healthcare practitioner can do for a concussed patient, especially one that is in a little bit of a panic stage, is validate their symptom profile. You have to validate that their symptoms are derived from something somatic and real, because they feel like they're going crazy and they don't know how to identify what they're feeling. For example, space and motion discomfort is very uncomfortable and very confusing to someone, and they often feel that it is something psychological, whereas it actually is coming from the ocular motor system, and they just simply cannot process either vestibularly from that VOR component. There's some visual blur, or they're just sensitive to space and motion, quite frankly, whether it be their head on their body on their head, or their environment around them. So validating the symptom profile and listening. The most brilliant clinicians in this realm, they literally sit and listen, and oftentimes unpaid will do, you're looking at minimum 90 minutes to 3-hour examinations on these folks.
I think that this has been such an interesting discussion, Jess, as somebody who treats people that have concussion, as well as somebody who, can continue to learn about the new research that's coming out and how we as physical therapists can really contribute in the healthcare team to helping people with these conditions. This has been a wonderful discussion, and I hope that our audience has really gotten a lot out of it, and I'm sure they have. We do ask one question at the end of all of our interviews, and that's if you could change one aspect of healthcare education in DPT or some other field, which aspect would you change and how would you change it?
I would love to see a generalized database of information that's being processed and passed on to our students. I mean, why are we siloing information? For example, that's more like a special topic like pelvic health or concussion brain injury. The MS population, even geriatrics are a special population. If we can get some form of consensus about what's being pushed out there, and whether it be, it's 2019. So if we can, just work on communicating better within ourselves, I think it would be a wonderful thing to see for the future.
Yeah, I think that that's a really great point. And, I know that a lot of people are probably going to have questions for you. They're going to want to reach out to you. Where can people find you on social media or through email?
Sure. So the best way to reach out to me is actually on social media. So on Twitter and Instagram. Instagram, not as much. Twitter more. I took a little hiatus there for a bit, but I'm back. So my Twitter and my Instagram are the same. So they're like Dr. Physical Therapy to Go, DPT, the number 2 Go, for both Twitter and Instagram. And if folks really need to send a longer email, I do consultations and things like that via telehealth and other consultation things, clinician to clinician. Jessica at pt the number 2 go.co. That's co like company. So Jessica, Jessica at pt2go.co. And I also have the podcast. Right now, I think we've been in over 40 countries with 15,000 downloads in our first year. We are at Concussion Corner on Twitter and at Concussion Corner on Instagram and Facebook as well.
So don't forget to listen to Jess's podcast at Concussion Corner. It's a great podcast, especially if you're wanting to learn more about concussion and mild traumatic brain injury. Thank you, Jess, so much for joining us today. And thank you for joining us on the Healthcare Education Transformation Podcast.
Awesome. Thank you, and have a great day.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare which is available in our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.